This is breakdown session number 4, and we're focusing on managing PPH at C-section. What do we know and what needs to be done? My name is Dr. Augustino Hellar, and I'll be the facilitator. And I have a pleasure today to introduce to you two of our great speakers who will be facilitating the session. We have Professor Arri Coomarasamy, who is the director of the Tommy's National Center for Miscarriage Research based at the University of Birmingham, and the director of the WHO Collaborating Center for Global Women Health at the University of Birmingham. His research includes numerous multi-center studies on, including the Champion trial and the new E-Motive trial on management of PPH. We also have Dr. John Varallo, who is the Jhpiego's Global Director for Safe Surgery. He is an OBGYN with over 20 years of clinical and surgical experience working in diverse settings in over 15 countries. And he has particular interest in preventing and managing PPH at C-section. So we'll have a presentation, and then at the end, there will be a session for Q&A. And you can type in your questions at the Q&A function below the screen. There is also a possibility of a French translation, so you can switch the translation to French if you prefer. So now I would like to welcome Professor Arri to start, and then John later on to continue with the topic.
Thank you, Augustino. Thank you for giving us the opportunity to discuss management of postpartum hemorrhage at cesarean section. So there was a study in 2010 that looked at the frequency of operations throughout the world and found that cesarean section is the most commonly performed operation in the world. There is also data, good data from a systematic review, that 25% of women who die during childbirth die from cesarean section. They die at or after a cesarean section. Now we know that about a third of those who die from postpartum hemorrhage. So this is a very important subject for us to get our heads around. So we will start with a declaration of conflict of interest. Neither John nor I have any. So what we will do in this session is to look at the epidemiology and the diagnosis of postpartum hemorrhage at cesarean section. Then John will take over management and give us a steer on where we might want to go from here. So in terms of diagnosis, we need to have a definition so that we are all talking about the same entity. And the diagnosis of postpartum hemorrhage at cesarean section has been a subject of some debate. Now, the standard definition of postpartum hemorrhage is, of course, to define it as blood loss more than 500 mils. But then that may not be appropriate in the context of cesarean section, and we will see why that may be the case in a moment. Many use the threshold of 1,000 mils as the definition for threshold for postpartum hemorrhage. The Australian College of Obstetricians, they use 750. But before we move on to defining what's abnormal, we do need to look at what is normal, and we will do that in a minute. Now, before I do that, let me just also tell you that severe PPH is often defined as 1,500 mils or more, and massive PPH as 2,500 mils or more. So that is almost half of circulating volume. The prevalence of it, this data comes from a very good Australian study. More than 1,000 mil loss was found in 5% of women having elective cesarean section and 7% of those who are having emergency cesarean section. Now, in terms of severe PPH, the prevalence was found to be 3% of those who are having emergency cesarean section. Okay, so we've got some brand new data for you. This has not been seen by anyone, I would have said, but the previous group have seen it, so you are the second group to see it. What we did was we looked at data to try to understand how much blood is normally lost during cesarean section. Now, when you look at all the studies, there were 38 studies, and we found that the average blood loss was about 600 mils. Elective cesarean section and emergency cesarean section, we were able to separate them out, and you find that the elective was associated with about 600 mils loss on average, and emergency 100 mils more. So if this is the average, you can see if you were to set the threshold for PPH definition at 500, you're going to end up with lots of cases of PPH. So this now looks at the prevalence of postpartum hemorrhage by the two definitions, 500 mils and by 1,000 mils. And what you see is that if you were to define PPH at cesarean section as loss more than 500 mils, then it is very common. If you were to look at studies that had used objective measurement of blood loss, there were 14 studies, and the prevalence was found to be 45%. So this is very high. When you look at elective cesarean sections, it was 41%. And when you look at emergency cesarean sections, it was 57%. When you look at subjective assessment, what's interesting is that there appears to be a gross underestimation of blood loss. Only 10% compared with the 41% here for elective cesarean sections, and 15% compared with objective assessment, which yielded 57% for emergency cesarean section. So you can see that subjective assessment may grossly underestimate the prevalence of postpartum hemorrhage. Now, when you define it as 1,000 or more mils of blood loss, then on average, you find that a 5 to 7% prevalence, slightly higher for emergency cesarean section, as you would expect. So that's good data on prevalence that we've been able to put together, and you are one of the few first people to see this. Okay, so we have this problem which is prevalent, but does it kill women? So my colleagues Soha and Shakila had looked at this, and they published this systematic review in the Lancet last year. They put together the data from nearly 200 studies from 67 low and middle income countries. And what they found was that the commonest indications for cesarean section were delay in progress of labor or a history of previous cesarean section. And they found that the mortality rate across the board, across all countries, was 8 per 1,000 procedures. But the heaviest burden was borne out by sub-Saharan Africa, where it was 11 per 1,000 procedures. They also found that emergency cesarean section was associated with twice as many deaths compared with elective cesarean section, and women who had cesarean section in advanced labor at full dilatation, they had 12 times the risk of mortality compared with those who had it at another stage in labor. So why are these women dying? The main cause is postpartum hemorrhage. 32% of the deaths during cesarean section were associated with postpartum hemorrhage, 19% with preeclampsia, and 22% with sepsis. So if you're going to address problems around cesarean section, these are the three conditions to be mindful of. And so what are the causes of postpartum hemorrhage? So the traditional way of looking at it, using the 4 T's does apply here. So we can have problems with the tone of the uterus, particularly if the labor was prolonged, or if there was an over-distended uterus, for example, multiple pregnancy. There can be issues with abnormal placentation, so placenta previa, abruption, and so on. There can be trauma, particularly with impacted head, particularly with second stage cesarean section. And the trauma can be laceration laterally into the uterine vessels, for example, or vertically down into the lower segment. There can be problems with coagulation, clotting, so abruption and preeclampsia can be associated with that. Now, in addition to these causes, we can also think about risk factors that would increase the risk of having complications from cesarean section. So these would include preterm birth, obesity, fibroids, and needing or having general anesthesia. So how do we diagnose postpartum hemorrhage at cesarean section? I think there is a need to make a distinction as to whether you are trying to diagnose this in the intraoperative phase or in the postoperative phase. Intraoperatively, the problem might be more to do with trauma, for example. Post-operatively, it could be atony, for example. And the methods that you might use for diagnosing could also vary. Now, people can detect postpartum hemorrhage visually or objectively by using collection drips, for example. Or you could look at physiological variables, and if there are alterations there, that could point you towards a diagnosis of postpartum hemorrhage. But what we can say is that visual estimation is likely to be very inaccurate to the point that it is probably not going to be very helpful. So I think we need to perhaps start to think about moving in more standardized, objective ways of measuring blood loss, and that being the trigger for some kind of action in terms of how you would manage. So talking of management, I will hand over to Joan to guide us through that.
Great, thanks. Thank you so much, Arri. And so now I'm going to talk a little bit more about the management and also about some of the prevention. And this is just to kind of frame it that, you know, we're still developing the appropriate algorithms for managing hemorrhage during and after cesarean section. And this is just an example of one that's been developed by Sufakis that looks at leading at cesarean section. I'm not going into great detail, you know, for each of these areas, but just use it as a framework. And in the subsequent slides, I want to go into some detail around some of the aspects for consideration as you're developing an algorithm. So one of those is around the importance of the anticipation and early recognition of hemorrhage. As Arri was talking about, one of the challenges we have is the accurate diagnosis of PPH. And we know that, as you pointed out, that the subjective method often underestimates that. And the risk with the underestimation is that you can slip into this into the massive PPH category without realizing it. And as this graphic shows, your chances for recovery diminish, you know, as the blood loss goes up. So I think, you know, one of the areas for research is around that, the more accurate detection and measurement of blood loss at the time of cesarean section to trigger that important action. So for prevention of PPH, so, you know, some of these, you know, elements are similar to what we talk about for vaginal birth, but certainly it's the use of uterotonics at cesarean section. The common recommendation is the use of oxytocin, 10 IU, either IM or IV. If you have an IV, you might as well just use the IV, and generally it can be, you know, as simple as putting, you know, 20 units in a liter of normal saline and running in 500s quickly. And so that's your 10 units. Then you continue that infusion for the ongoing uterotonic benefit. Then there's the combination of ergometrin and oxytocin, as long as there's no hypertensive or cardiovascular concerns. We talked yesterday a bit about carbetocin, heat-stable carbetocin, and that's a promising area, especially where the quality of oxytocin is a concern. We know that it is more effective than oxytocin, so that's a consideration for, depending on the context, for inclusion in an algorithm. The other interesting area is really, is there a role for prophylactic TXA? We know that there is a recommendation for TXA for treatment of PPH, but there are some studies that are looking at TXA either for all cesarean sections or for those who are at high risk. And so at high risk is, for example, women with antepartum hemorrhage or with abnormal placentation like placenta previa or placenta previa, we know are very high risk for hemorrhage. And we know that with the use of TXA, that you have markedly reduced blood loss, massive hemorrhage, transfusion requirements, and additional uterotonics. So certainly an interesting area for further research and consideration for an algorithm. So the surgical management of PPH at CS, and I'll talk a little bit more about the medical treatment, because the evidence for the medical management tends to have higher quality evidence than we have for surgical management. And we'll talk about the surgical management for when the medical management for uterine atony fails. But as when Arri was talking about the 4 T's, one of the common T at cesarean section is trauma. So ruptured uterus or abnormal placentation. And there, certainly uterotonics aren't going to work, and some of the suture techniques that I described later are not going to work in those situations. So it's understanding the cause and directing your management to that cause. So this graphic just breaks down the algorithm when we start talking about uterine atony at cesarean section. And the first step is to assess and resuscitate. So looking at vital signs, accurate measurement of blood loss, IV fluid resuscitation, blood transfusion as needed. Then the medical treatments is the additional uterotonic. So whether that's additional oxytocin infusion or adding ergometrin according to the patient's condition or risk factors, or misoprostol as additional uterotonic. If TXA has not been given prophylactically, then given TXA has been shown to decrease the risk of ongoing PPH. And then uterine massage or bimanual compression. And then making an early decision for surgical management. And the surgical management, and this list kind of goes from the easiest to use with the least amount of complications through to the higher risk of complications. And I'll talk a little bit more about the uterine compression sutures, like the Blynch, which is really promising because of its ease of use and its effectiveness. And then there's the uterine devascularization, stepwise devascularization, starting with the uterovarian artery, the uterine artery, and then hypogastric artery ligation, which tends to be a bit more difficult, especially in non-specialist hands. And then hysterectomy, which is really more of a last resort or a salvage method because of the technical difficulties, especially at cesarean section, and the risk of complications with that. And if you're doing a hysterectomy, then doing a self-total hysterectomy is the recommendation. So the keys to successful surgical managements, quickly just outline these. So anticipation, we talked about early identification and management according to cause. Using the cesarean section adapted WHO surgical safety checklist, I think is really important. It's what we've used in our programs, and we know that, and we show that you can decrease perioperative complications and death by 30 to 50% with use of the checklist. I think it's really important is some of these non-technical skills. So situational awareness in the operating theater, teamwork and communication. And we've shown that these non-technical skills are really essential for team performance and improved outcomes. And so that's something that we build into our Jhpiego Safe Surgery programs, is that focus on these non-technical skills in a team-based approach. The early decision to use compression sutures for uterine PPH is that ongoing blood loss. So as we see, the more blood loss, the more difficult it is to treat. So making that early decision to use those compression sutures and knowing how to use them, and the post-op care and monitoring. That tends to be a gap in that the recent study in the Lancet by Picard and group showed that the vast majority of deaths occur within the first 24 hours. So care doesn't stop in the operating theater; it continues in the postoperative. So I'll just quickly touch on the Blynch suture if you're not familiar with that. It's a simple procedure. It was developed by Dr. Blynch in the 90s. It's a simple procedure to do. It takes less than 2 minutes to perform. Easy to learn, easy to practice on a simulator, in a very low-tech simulator. Does not require special equipment or supplies. It's just a suture that you have operating theater, and the effectiveness is generally 75 to 90%. And the graphic on the right kind of shows how it's performed, and we'll go into great detail with it. But it's very simple. It's just certain landmarks. You insert like 3 centimeters from the medial side in out, and then you loop it around and to the posterior, do the same, and the posterior, come back to the anterior. And then as your assistant is compressing the uterus, so pushing it down, then you tie the suture. So it's compressing the uterine wall. So it's essentially creating a contraction, and you can see the photo there. in the lower right, that's from our Cambodia program that shows what it looks like afterwards. And it's effective about 75 to 90%. There's some variations on it, but really the Blynch is the one that has the most research behind it, and is very simple to use, and it is effective. Some considerations is not to use permanent suture because of the risk of bowel herniation or strangulation. You want something that's absorbable, and then there's some concerns regarding risk of uterine necrosis if combined with devascularization suture. So generally, the general recommendation is that just use a compression suture, and if that does not work, then to move on to further surgery. So where do we go from here? So as we said, that there's we still building the body of evidence, and some of the work we're doing, or it's being done with the Gates Foundation, is the emotive study, so the Caesarean section arm of that. So looking at developing a strategy for early detection and management of PPH Caesarean section, so looking at bundles plus algorithms, seeing what the right combination is, and then developing a strategy for implementation. And other work is the Where and Why project, which is developing a very powerful tool to understand the epidemiology of Caesarean section at provincial and district level. So the key takeaways, we know that Caesarean section is a significant risk for hemorrhage and maternal mortality, and we know that Caesarean section rates are increasing worldwide, so it's important to address that. And if we're really going to make any kind of real headway on maternal mortality and on PPH as contributed to that, then we need to include surgical managements for PPH and managing hemorrhage at Caesarean section in all of our programs. Evidence is building for the most appropriate bundles and algorithms, but we know that more research is needed in that area. And any implementation requires more than just the technical competencies. We need to include the non-technical competencies in order for it to be successful. And the Blynch uterine compression suture is really an attractive method that should be included in all programs that provide Caesarean services, especially those with non-specialist work. So I'll end there. So thank you, and we'll open it up for some questions.
Thank you so much, John and Professor Arri. So if you have any questions, please type them. Currently, we have one question from Sapana, and he is asking, is it better or mandatory to do a bilateral uterine artery ligation or utero-ovarian? I guess related to the uterine vascularization that you described, John.
Yeah, so it's a good question. You know, they talk about stepwise devascularization, and generally it's the uterine artery ligation that's going to be more effective. And the importance is the location, of that. So you want to do that. You want to get the descending branch, so below the level of the uterine incision, and then you can recommend even doing a second bite higher up on that side, but and doing it bilateral. And then the next step is to do the utero-ovarian. But it's important to continue to assess if you have ongoing bleeding. And I think that's one of the things that can be a little bit of a challenge. So ensuring that you're looking for the bleeding from the vagina, because this is not going to affect the uterine anatomy, right? So, I mean, you're not going to see the uterine tone improve. You're just trying to reduce the pulse pressure, essentially. But those are relatively easy to do. It's when you get into the hypogastric artery ligation where it becomes technically more challenging, especially for non-specialists.
Thank you, John. We do not have any question at the chat, at the Q&A function, but probably can you share with us, because I know one of the challenges we face in these programs is for the providers to have adequate practice in simulation. Can you describe how simulation can improve C-section skills and also skills for Blynch application?
Yeah, it's a great question, and it's something that we've have incorporated into our programs, because I think that's really important. A lot of surgical skills, we tend to think that it's kind of like on the job, training, and so it's just kind of you're in the operating theater to do it. But we've really have come a long ways with relatively low tech simulators, And we've recently developed one with Laravel, the C-section simulator with that helps with the practicing the surgical technique. Not only for cesarean section, so even like the layers going through the skin all the way down to the uterus, and doing and being able to do the Blynch. And the nice thing about that as well is that we integrate that into a team-based approach. So we're using the surgical safety checklist. We're looking at communication skills, teamwork, and communication, not just the technical skill, but kind of building that in as a comprehensive approach to it.
Thank you, John. There's one more question at the Q&A function. Lee is asking, and he's saying, thanks for the presentation. You mentioned the where and why study on epidemiology of C-section. Can you share more information?
Sure. I think this is best done by doing a screen share. Can I do that? Right, let me just open this. Okay, so this is taking the example of South Africa, and you can see at the level of provinces how many live births there are, and also how many women have died. This is mortality from cesarean section. Now we can actually break it down. We can then look at number of cesarean sections. We can look at the cesarean section rate. The website hasn't been optimized yet, so it might take a little while to load up. But yeah, so you can now see the cesarean section rate and how it varies from province to province. But we can actually take it down to the level of district. Let's see if we can do that. Okay, so this is now cesarean section at the district level in South Africa. And similarly, we can provide the MMR. So this is actually cesarean section related deaths at the level of district. And so this is the MMR. This is just to give you an example, a demonstration of the granularity of the data. This could be used for research purposes, for planning services, but also for identifying positive outliers. There are those who seem to be doing better than others, even within a given province, and this would allow us to identify such districts and see what we can learn from them. Hopefully, this would generate the sort of data that would be useful for many people.
Thank you so much, Professor Arri. I guess we are out of time. Ryan can confirm, but I've just put on the chat function the link for the website, and we should be getting back to the plenary.